Sonuncu sesiyamız başlayır. Sesiyanın ilk məruzəçisi Saltkova Anastasiya. Kraniomandibulyar sistemin funksiyasının kliniki instrumental analizlərin vasitəsilə dəyərləndirilməsi. Buyurun. Saltkova Anastasiya 2008-ci ildə VieSID'in komandasının üzvüdür və kraniomandibulyar sisteminin kliniki və instrumental analizləri üzrə ixtisaslaşdırılmış mütəxəssisdir. Monitoru boş.
Yeah. Hello, everybody. Maybe half a minute for everybody to come back. Okay, dear colleagues, thank you very much for inviting me here. And I heard so much about Baku, never went here, so it's my first time, but not the last time, because I think I'm going to be coming for the basic course and work with Timur here. Thank you for everybody who decided to stay, even it's Sunday. So, my name is Anastasia Saltykova. I work in Vienna as a teacher and instructor, but I also work in Moscow as an orthodontist. And I actually travel every month forward and backward to treat patients, to teach students, and so on. And today, my lecture will be focused on, I would say, clinical part of application of our concept. So I want to demonstrate you the big advantages that we have when we work with this system, what it gives us as clinicians. So my story with professors starts a long time ago. I was 24, 25 when I came for the course for the first time. And this is how I fall in love with what he's doing, with his teaching and his concept. And I decided to stay. So now I'm 40, so I was with professor and with concept for, let's say, minimum 15 years. And I hope I actually got some experience and knowledge that I can share with you. Okay, so I want to show you for the beginning interesting, in my opinion, case. It's a young girl, she's 20 years old only, and her main complaint already is the joint pain. Right side is clicking, it hurts. She hears the clicking every time she's chewing, every time she's opening, and this is her main complaint. Not much of other problems, actually muscle fatigue during chewing as well, but mainly clicking. And actually very nice smile, you can see. Nice straight teeth, and I'm orthodontist, right? So I usually expect people coming with a crooked teeth with some problems. This is her profile. Again, I would say maybe a little tendency to class 2, but nothing serious, right? She looks okay, she looks like a class 1, beautiful teeth, and this is her occlusion. So looking at this kind of occlusion, which is class 1 with maybe slight tendency to class 2, you're wondering, how come she has the serious joint pain? How come she comes complaining about this? And with the conventional diagnosis that all the orthodontists do, it's very difficult to find out the reason why. So you do your photos, you look at the occlusion, teeth looks okay, not much abrasion, not much crowding, nothing, symmetry is okay. You can see on the upper incisor a little crack, okay? A little chipping of the incisor. You can look, if you look carefully, you can look at the tongue of the patient, and on the side of the tongue you see this interdigitation, we call them. It's a sign of hyperfunction, it's a sign that she's bruxing a lot and pressing the tongue against, right? And it's true, she is in her period of her life when there's a lot of stress. University, she entered university, it was a lot of problems, very difficult to study and so on. And of course, we go through all the diagnostic. We have her models mounted in the articulator. Here, when we mount, you can see a little more class 2. So actually, when you take a central relation, she goes a little more back from ICP. And Usually what we check in the models mainly, not the outside, we always look from the inside, because the real occlusion you can judge only from inside the model. And here, on one side, on the right side, cusps are actually fitting pretty nicely, on the other side, not. But again, nothing really major so far. X-ray. All teeth present, including the wisdom teeth. You can also check the condyles. Condyles looking okay. Left side, okay. Right, you can see a slight flattening. So you might get a little suspicious that something is going on there. We also do a CT for the patient, a big one, so the joints are also there. What would you say? I would say the right side, maybe a little posterior, and the left side also. Just a little slight posterior position. But looking okay. Okay, we do the analysis of the skeletal structures. She is quite symmetrical, beautiful girl, nothing. In the airways analysis, you can see a little narrowing of the airways, but they also said it due to some pathology of the throat, so some inflammation or something. Okay, usually, right, more or less the diagnosis standard one ends here. And if this kind of patient comes to you, you do all these diagnoses, maybe you do intraoral scanner or something, can you really decide a treatment plan? Can you really make a diagnosis using this? In these kind of cases, it's very difficult. It's like looking nice. Yes, an orthodontist, what can I improve? So we need a little more information. We need really more data to make a diagnosis. I do for all my orthodontic patients a full diagnostic, because orthodontic treatment is like a full mouth reconstruction. We change everything. We completely create a new occlusion, a new mandible position. So we have to be very careful when we do. We need to know everything about the patient, how the joint are functioning, how muscles, and so on. So this is a necessary thing. So we do Bruch's checker. We do the Bruch's checker because we want to see what is happening with the occlusion at night when the patient is bruxing. Is there interferences? The interferences can be very dangerous for the muscle, for the joint. Then we, of course, do the movement recording. We need to see how the condyles are functioning, how they're moving, because the main complaint has to do with the joint. MRI is always nice to have MRI to control yourself. In some countries it's not so easy. Unfortunately in Moscow it's super easy, so I do even several MRIs for the patient during the treatment. We control the muscle palpation and so on. And of course we mount the models in the articulator. So a little more details about our patient. Our skeletal pattern we analyze, and she has a skeletal class 2 with tendency to class 1. So our kind of first impression was right, a little tendency to class 2. And also she has a low facial height diminished. Everything else is okay. Incisors are fine, not so bad. Okay, Bruch's checkers, and here it starts. So the Bruch's checkers shows us the dynamic occlusal pattern of the patient. And we usually expect in the nice harmonized occlusion like a canine guidance maybe canine, maybe with premolar working together. And of course we don't want to have any interferences. We don't want to have dynamic contacts on the molars, on lateral intrusive side, and also we don't want, of course, on the balancing side. And this girl, she has everything. She has the canine working together with premolars, also lateral intrusive interference on the molars, and also on the balancing side. So she has a lot of interferences during bruxing. I sent her for the MRI even before I start to do diagnostic, and here we go. I don't know how good you are with MRI, but there on the right side you can see a condyle, and next to the condyle, I can show you, and next to the condyle here, you see this white line, it's a liquid, right? Under the disc, and the disc is just here in front. And on that side, not a very good quality, but on the diagnosis it was partial dislocation. So, right side, she has a full disc dislocation. So the disc moved from its normal position forward. And on the left side, partial. So a little bit shifted, not completely, but on the way. In open mouth, the disc is on place, everything is fine, and here also. So the diagnosis, full diagnosis, sounds like this. Disc dislocation with reduction on the right side, and the left partial disc dislocation with reduction. Okay, colleagues, what would you do? How do you treat? Because here we have a diagnosis, but we don't have here the tools and instruments to proceed to the treatment. I know what's wrong, but what to do? How can we find out what's happening and what our next step? For this, the absolutely necessary is this kind of diagnostic. We use a condylograph to record the movement of the condyle. And every time you have a disc dislocation, if you're lucky, you will have this kind of picture, because this is a super typical picture. This 8 figure on the right side, this is how the clicking looks like for us. So for you, because you haven't been in our courses yet, probably this is just like a graph, so it's very difficult to understand. So imagine this, okay, behind the condyle. So this is what you're looking at. The condyle is moving, drawing this kind of pathway. We can see this one in dynamic. Look, click one time, and on the way back, another click. This kind of changing characteristic, right? Once again. Oh, sorry. And on the way back. And probably you saw Kristian was showing video of the normal functioning joint with the disc in between. And this is an example from the same guys that they did an amazing video of how the disc dislocation looks. Look. Okay, repositioning, and on the way back, losing the disc again. So going forward, forward, forward, forward, forward. Disc is on place, and on the way back, it shifts again. And the same we see here. Okay, look here, the same. Going without the disc, disc is on place, and from here on, disc is okay, and on the end, losing disc again. This kind of tracing information helps me to find an exact position for the condyle when the disc is still on place. So, I want to stop her from going so much backward and avoid the moment when the disc is sliding forward. So I want to stop her when the disc is still in place. Exactly. Reposition, and on the way back, look, this line is the disc on place, and here, so I'm going to stop her here in this one. Okay, it's nice. You look at the graphic, this position, but how? In the software, when I put a cross in any position I want, on the corner there, I can read the exact coordinates. It's what we said again. Navigation is about knowing where you are, and from where you are, you can go somewhere. So if I know where my coordinates, I need some kind of tool that will bring me there. And because all our system is kind of united with the same coordinate system. Look, this axis orbital plane that we use, it's the upper part of the tracing you saw. It's also upper part of the articulator, and also you have it in the cephalometric tracing. So this is my X coordinate, okay? And the same here. So you have any movement you record during the condylography. You can replicate this movement in the articulator. And also you can replicate it in the even cephalometric. We have this kind of dynamic cephalometric. Okay, So this is what I like about that system, that I have the tools to proceed from diagnosis to the treatment. This, on the right side, is articulator, and that one called variator. Variator is a device that allows us three-dimensionally to change mandible position even to a tenth of the millimeter. So this is how I did. I took these numbers, x on the right side 1.38, let's say 1.4, z 2.7, and I moved my condyle 1.4, 2.7 in the articulator. So if I manage to do the right side and I put it in the correct position, what's going to happen with my midline? It will shift. So I need to take care of another one, right? Another one I also have to move. And it's already partial dislocation. So I will just simply move the other side in this position. So altogether, look, I moved the mandible 1.5 millimeters forward, approximately, okay? It's not much. It looks here huge, but it's actually 1.5 millimeter. And this is the result. This is how it looks. So I believe that she has to be in this position. This is her position where her joint feels the best. The disc is on place on one side, and another one, probably I can prevent the further disc dislocation. Okay, so we have a position. We, of course, need to test this position. We cannot just trust 100%, so we always test it on a splint. We do a splint for the patient. Patient wears the splint. First, we check, is it clicking, not clicking? Then we repeat the MRI to be sure that we're in the right position. And of course, the design of the splint has to be done in a way that the patient cannot go backwards so easily. So once we change the position of the mandible, our task is to stabilize there the patient and doesn't let the patient go back. So these structures here in front of the premolars, this is called retrusive control. This is exactly what keeps the patient in this new position. Okay, so we do the splint, and then we send her home. And of course, we also check in the retrusive. See, we move the mandible back, and this kind of step in front of premolars is supposed to keep the mandible. All other teeth are disoccluding. And every time she wants to bite, she has to slide forward. This is how the retrusive control works. Okay. She's wearing the splint, and we are preparing her for the orthodontic treatment. Sometimes I start with only brackets on the upper to prepare the upper jaw. If there is a narrowing or crowding, it's very simple. I just start a little bit, just making a nicer shape to prepare the patient. This is what I did. She's still on the splint, not for the photo, but she's wearing it every day. And I start with upper alignment. So 2 months straight wire, and the 3rd month already multi-loop wire. I'm also a student of Professor Sato, so I'm using the multi-loop technique. Lower is the same, but upper we change a little bit. We make it wider. And then we mount a new upper with the brackets in the same position that was the one before, and we fix therapeutic position using the overlays, looking like this. Actually, she has a very nice morphology of the upper teeth, so we decided to use only overlays for the lower because the upper has really nice cusps and is possible. But most of the time, I think we do upper and lower. And this, we use different now techniques. Sometimes we do the CAD/CAM system overlays, sometimes, but this is just a wax up, handmade, and we transfer it with a special key, transparent key. So this is how it looks from inside. Remember, right, from inside is very important. We need to control that every cusp is on place. And here how we transfer. So I fix her in this position. She's still not clicking, everything is okay. And very fast from that point, it's easy and fast to close her and finish. I think it was a little less than a year altogether, the treatment, but also it took a little longer because we had to remove the overlays. She has 2 nice teeth to cover them with overlays, permanent ones. And this is how we finished. What do we have to sacrifice a little bit? We will have to do for her lateral incisors restorations. In order to reposition the mandible, I had to widen the upper, right? And if I widen the upper, I have gaps. And this is the end, this kind of space, but we close it very fast with restorations. And I think it looks nice. Okay, now it's time to check the results and judge yourself. How did you do? So I don't have a model from inside photos, but I found the scan. So I can show you how the occlusion looks from inside. Of course, she needs some treatment, like always. They're not very good in oral hygiene, but anyway. And this is how she looks afterwards. Her profile, a little nice, I would say. And also comparison, before and after. Profile is better, but to prove it even more, we can check the cephalometric tracing. And here's the result. She was a class 2 with tendency to class 1. Now she is class 1 with tendency to class 2. So she went a little forward to class 1. She has normal low facial height. Everything is okay from skeletal point of view. And of course, one of the most important is the joint. So you can see there the position of the condyle, exactly how we moved it, a little forward, a little down, and the disc now is in between the condyle and the fossa. And here also it was so backward that we could not even see the disc because it was all black. So now we see the disc. And opening, also everything is okay, nice. And this case is a very lucky one, first of all. She's a young girl. And she has such a nice, loud click, very beautiful shape of the tracing. These usually have a very good potential for reduction. But if there's already a lot of years passed and the disc all the time going in, out, it's already thin and you don't have such, easy success. So it's not always like that. But at least you have a nice tool to do and try it. And here is a condylography after, a little shorter, but because we moved her, but everything is really nice. Clicking and non-clicking. Another thing that I have to admit that the dynamic occlusion is not perfect. This canine that she abraded before the orthodontic, it has to be restored because you see the other side, when she is moving to the side, canine is disoccluding all the other teeth, but on this side, not. So we will have to restore her canine also. Okay? So, nice, simple, but I think it illustrates how important to have this kind of diagnostic, because otherwise, you don't know what to do. Okay, another case, a little more complex. This was sent to me by a colleague, a prosthodontist, and the simple problem, they managed to put the implants, but they don't know how to put the crowns, because there is no space for the crowns. This is a nice lady. If you make a photos of the patient face, please be careful posting it, okay? Okay, you can see. You can see a little plane, occlusal plane count, right? You can see the lower teeth also, height, I would say, on the left side is much lower. This is her profile. And this is the occlusion. So midline is really deviated to the left side, diastema, and this is the surgeon problem here. And other side as well, you see on the models later. So you see, okay, because of the dental velar elongation of the teeth, there is no possibility to actually proceed with prosthetic work. Okay, so what would you do? You would intrude the teeth, close the diastema, make intrusion of the molars or something? Actually, no. First, we do diagnostic and we really check. She is a class 2, low facial height is normal, okay? And her brow checker, really, she's not bruxing that much. But you can see, even if she's bruxing, there is no canine guidance, there is, because of the very deep bite, she abrades the palatal part of the incisors and also interferences on the molars. If molars are erupted like this, of course, during the movement, everything is going to be. But, surprise, surprise, this is her condyles and the joint. So this is, let's say, a really arthrotic joint already. If you start work with a patient, how can you figure out, even before X-rays, this patient usually, and she also said this, tell us that they used to click before, a long time ago, but then they stopped clicking. So everything went perfect. It healed itself, the joint, the clicking stops. But the truth is, they probably have a disc dislocation a long time ago with reduction, but now it's already without reduction. And degenerative changes of the condyles are so advanced that you can see this flat surface completely. If you want to have a little more details about the shape, we do the CT in different cuts. So yeah, no space. See between the condyle and the fossa where the disc is supposed to be, it's super, super narrow. So that means every time she's functioning, she's moving one bony structure against the other, basically, with maybe a little something in between. It looks like this, probably. It's not her. It's just the same videos. So it's really, really like, you know, abraded surfaces against each other. And what clinically this patient report? They usually report the crepitation, right? This kind of sandy sound in the joints. And again, if I would not have the instruments to do, it would be maybe not so easy. So probably classic, you would go for the intrusion, right? Intrusion of these molar, mini orthodontics. But what we did, we, of course, did the condylography. And also, this is another typical diagnostic sign of arthrotic joint, is this flat, limited movement on the side. So it's like this. When you see that line in condylography, you imagine that condyle. What would you think would be helpful for this kind of joint? Do we need to try to recapture the disc? To put the disc in place? No. It's way too late for the disc. It's already deformed, degenerative. So we need to stop this process, exactly. We need to increase a joint space, so we need to pull the condyle a little down, right? To make a space in between the structures. Again, it's because we have condylography. We can do it. But also one more thing, I not only want to go down, I want to go a little more forward because the posterior part of the condyles and also because of the asymmetry. So this was my decision. This time you can see I'm not following the movement pattern of the patient because I know it's with compression. I go below. Cinzia was showing you in the presentation the different ways. You can go along the line, you can go under the line. And in this case, I have a class 2 asymmetrical, so I have to go a little bit forward but under the line to have more space in the joint. This is what we did. You put the stars there, so you can see the X is 1, Z is 2.7. Also on the other side, I think X is a little less than 1 and Z is 2. I go to my variator again and I put exactly that numbers in the variator. First for one joint, then for another one. I put my models and I check, do I like this position from the point of view of further work, prosthetic and so on. And actually, it's not so bad. Look at the molars. Is it possible to make a prosthetic work in this position? Here. It's possible, because these tooth are also going to be restored. So it's not looking that problematic anymore in this position. And of course, we need to check it with the splint, always. First, we do the splint, the patient wears the splint, and only after we confirm that it's okay, we continue with the next step. So the next step in her case would be crowns on implants that will hold this position, and some overlays also on the tooth. So, okay, this is how it looks on the models. And you can see that we always, when we do this kind of overlays, we try to make a really, really strong morphology. It's important. You cannot make a flat crowns expecting that the patient will stay in the new position. You really need to take care. And this is how it was in the mouse. And from this, already the orthodontist can start working, right? Preparing for the total mouth reconstruction. So this is what I did. And in this case, see the occlusal plane is much better now, the lower teeth. And this is what I did, and I did it this case using the aligners. First of all, because she has posterior teeth implants, it's perfect. So implants stay in, there is no intrusion, and it's patient's choice also. She can choose any treatment she wants. And the setup, or like ortho-check, was like this. Closing the diastema, changing a little bit the width, and also correcting the sagittal gap. And the teeth that we're using for the overlays, they are not moving at all. Even if it's not an implant, a real tooth, we try to keep it as stable as possible. And here is in the middle of the treatment, let's say, or closer to the end, just some, on the, and this was the final. So this is how we finished, and now she's totally prepared for the prosthetic work. She wants to have full mouth reconstruction, veneers, including everything. And time to check yourself, like always. So she's still skeletal class 2 because I moved her only a little bit. With this kind of joint, I cannot move a lot forward. I have to go more down than forward. And low facial height is still normal, and this is how she looks. Actually, nicer and better. The condyles, I don't expect the condyles to restore, let's say, and get much better. But the comparison of the condyles before and after, I think I have somewhere I show you. So it just stays the same, but maybe a little longer, because it's already arthrotic. I cannot do that. I just try my best to prevent the degenerative changes further on. And this is before and after. And I like this also, the plan, orthodontic plan, the reality, and this is also intraoral scan after, the control one. Okay, what do you think we should have in the joint now? These upper pictures is before, and the lower pictures is after. Look, please, at the, of course, I would ask maybe even more space before prosthetic. I would maybe go a little more down, actually, but the increasement of this joint anterior space, this is what we're looking for. So we have to go down with the condyles. And just from time to time control her and send her again to MRI. No symptoms. She didn't have symptoms before, basically, because all these kind of chronic arthrotic changes, they don't even complain. You will be surprised. Some of your patients for sure have it. You don't even notice most of the time. Okay, so this is the possibilities we have as a, let's say, orthodontist. A little more case I show you, but this is different direction of the case. So I have a patient, and she is complaining about the smile aesthetic, and she really, really wants veneers. She has difficulties to smile because it's a lot of tension, and every time when she talks, you can only see her lower teeth. You don't see upper teeth at all, so they're completely covered with the lip. Here she makes an effort to smile and to show the teeth. Occlusion doesn't look also bad, but definitely she needs reconstructions, right? She needs, for the front, for the aesthetic reason, but also look at the condition of the molars. All of them needs to be restored. Okay, so we do mounting, we do a hinge access location. It's important here, the hinge access location. We check her joints. Not so bad. This is protrusion, retrusion, a little deviation, open, close, but you don't see here, right, signs of clicking or arthrotic. She is more or less okay. Then, cephalometric, skeletal class 1. and low facial height is normal. Ooh. But normal, it's a huge range, right? So our norm is actually on the very, very border of not norm. See, the red line is in the border between green and the blue. So she's just by maybe 1 degree in the normal range, but actually she's quite low from the average. This is the average vertical dimension, and this is where she is. So quite low. They tried to raise the vertical dimension with a prosthodontist and make a mock-up of the front teeth, and even though front teeth looks long, they're still not visible under the lip. So we need to do something about this. We made a sprint for her verticalization. So the main goal here was to increase her vertical dimension and try to do it orthodontically. So this vertical dimension is actually the one that we want to keep for the future. And this is how we did. We did the overlays to verticalize her and keep her in this height. Same here, just key transfer of the composite restorations. And here also, because she's going for total mouth reconstruction, I can do for her Invisalign or aligner treatment. And this was the plan. Everybody was telling that this is a little crazy. Verticalization is not working very good on the aligners, but decided to try. And this was in the middle. This was in the end. But you cannot judge looking here because you don't see the vertical dimension, right? She also was like this before, occlusion-wise. But looking at the face, you can. So the increase of vertical dimension was pretty nice. Why I can do like this? I mean, maybe some of you are very careful with verticalization of the patient, right? You heard somewhere that they say if you verticalize the patient, you might create compression or something in the joint, but not in the case of hinge axis location. If you mount your models with the true hinge axis, it gives you freedom to verticalize the patient and be sure that there is no compression in the joint or any kind of movement, because you're really rotating in the joint. So the joint is safe and stays in place. And this is the profile. See, she is again, low facial height in her case is normal, but what range normal? So we are really, really closer to the average now, right? So we were there, but now we are here. And before and after cephalometric is kind of nice verticalization. She's super happy. Her face changed. She's posting all over the Instagram, sending us patients and everything. And now when she talks, she says, I can see my teeth, and even without veneers, she already can see her teeth. So this is what you can do if you know what you're doing. So it's kind of risky to do this kind of mandibular repositioning or verticalization when you don't have completely sure equipment to do this. But if you have something like condylograph articulators, then you can do amazing things, I think. Okay, thank you very much.
Sertifikatı təqdim etmək üçün Azərbaycan Tibb Universitetinin Terapevtik Stomatologiya Kafedrasının dosenti Vaqif Həsənov.
Mikrofon.
Спасибо большое.
Hörmətli həmkarlar, mən ilk növbədə sizin adınızdan təşkilatçılara Slavicek
Ian Tesler.
bu Slavicek konseptini Azərbaycana gətirdikləri üçün təşəkkür etmək istəyirəm və təşkilatçılar adından sertifikatı xanım anesteziya maraqlı çıxışına görə təqdim edirəm. Təşəkkür edirəm.
Thank you very much. Thank you. Спасибо. Хорошо сказали? Что-то хорошее про меня сказали? О, фото. А, посерединке?
Konferansımızın sonuncu elmi çıxışı tester İAM. VieSID mükəmməlliyə aparan zəruri konseptlər.
Well, good afternoon, everyone. It's an absolute pleasure for me to be with you today. I wish I was actually with you. Instead, I'm in Canada, early morning. Speaking about VieSID is a passion for myself and all of us instructors. I've had the honor of being associated with Professor Slavicek, Kristian, and VieSID since 1988. It's a long time, but Professor Slavicek had a huge influence on my life, both personally and professionally. I have a curious title. It's Essential Concepts to Elevate Your Game. And in this case, we'll see today why I'm talking about it as your game. And I'm going to offer you kind of a summary of what you've heard today, this day celebrating VieSID. And I'm going to give you a review that also includes some points that you can actually use in your practices as soon as you can. The beauty of being able to travel around the world speaking is that you get to know a lot of dentists and you get to see a lot of different situations. So these are some of the things that I've learned. No matter where I am, it's fascinating how our patients present with the same issues, no matter what country they're in. What differs is actually us. We have varying skill sets, knowledge, and our desires to learn. We have the option of being what's called a single-tooth dentist. And I think, honestly, that's what most dentists aspire to do. But to me, this is like an ostrich that sticks its head in the sand. Our patients are presenting with a lot of signs and symptoms that the vast majority of dentists don't see. When we practice functional dentistry, we actually have to make a conscious effort to see what is there. VieSID provides us the tools to do this. And I know from clinical practice for 43 years that our patients are better served when we get our heads out of the sand. So now a curious question. How do you all make decisions in dentistry? Your treatment planning, what therapy should you provide? How do you make decisions in your life? One of my passions is studying game theory, which was started by John van Neumann in 1928. And this concept comes from a book that is excellent called Thinking in Bets, written by World Series of Poker champion Annie Duke. I want to compare two different games. I know you'll see why in a second. The first would be chess, and the second is poker. So in chess, the board is seen by both players. If you and I are playing, we're both looking at exactly the same scenarios. In this case, no luck is actually involved. Ultimately, skill will prevail because, well, each of us sees the entire situation. You have complete information, which is called a deterministic model of prediction. But what about poker? As we know, in poker, all cards are not known. Therefore, there's an element of luck. A skilled player will win more times than the unskilled, but you do have incomplete information. And we know that luck and probabilities are involved. This is called the stochastic model. But here's the thing. Decisions in our lives are like poker, not chess. And this really applies to all of our dental therapies. Let me explain further. You see, treating any biologic system is inherently like playing poker. It's impossible for us to know everything about the presenting system. Therefore, we have to understand probabilities. So how do you improve your odds in dentistry? Well, I listed 5 items here. One is education, which is what you're doing today. You have to be incredibly organized, and you have to be absolutely thorough in your diagnosis and treatment planning. I found in my life, study groups such as yours were the best way to gain information. And ultimately, as I've gotten older, teaching makes me study, it makes me learn, and it gives me the opportunity to share what Professor Slavicek gave to us throughout my career. So how do you stack the odds in your favor? I'm going to give you a thought experiment. I sat down one day and wrote out 30 variables. These are 30 parameters that we should consider when we're doing our treatment planning. Now, arguably, we can rank these 30 variables from the first most important one right to the 30th most important one for each patient. But of course, different patients will have different variables in each position, 1st through 30. Mathematically, that's called 30 factorial. And when we do 30 factorial, that's 2.65 times 10 to the 32nd, which is 265 octillion combinations. Now that's a really huge number, but it shows you the incredible variability of our patients and why we have to stack the odds in our favor. Now we've all lived throughout our careers hearing about evidence-based medicine and thus evidence-based dentistry. As time goes on, most of us start to realize that there are some issues when we just follow an evidence-based model. In this article in Contestants in 2021, Sarati et al. Talks about functional assessment of the stomatic gnathic system. And he said that there's actually a lack of general consensus on performing a functional assessment of this system. He states that dentistry needs objective, dynamic methods of analysis for the evaluation of the stomatic gnathic system that embrace the principles of personalized medicine. Well, what is personalized medicine and personalized dentistry? This, I believe, is an evolution of evidence-based medicine and dentistry where we start to focus on gaining as much information about each patient as we can so that we can truly personalize their treatment. There actually are articles in the literature, this one by Kornman and Duff in the Journal of Clinical Research, called Personalized Medicine, Will Dentistry Ride the Wave or Watch from the Beach? And they state that there are 3 oral conditions that meet at least 2 of the criteria for using a personalized medicine approach. Number 1 is something with uncertain treatment outcomes. And number 2, high impact consequences of inappropriate treatment. Now, really pay attention to that statement. That is talking about iatrogenic dentistry. So these are the 3 that they stated: severe periodontitis, rampant caries, TMDs, and chronic facial pain. Well, VieSID is dedicated to education in the personalization of dentistry. We know that clinicians' knowledge and skills have to be appropriately applied in our treatment. We need tools that would provide precision diagnosis and treatment planning, and we have to have the highest quality precision care when we provide our therapies to our patients. VieSID is focused on the theoretical, clinical, and technical aspects of high-standard, individualized functional dentistry. Again, it's a not-for-profit institution for the advancement of occlusal medicine. So let's talk more about occlusal medicine. When we get together with our patients, we do collect a lot of data. My colleague and friend Anastasia just showed you a beautiful case where on surface it looked absolutely perfect. But the more we studied, the more data we collected, the more we found a way to treat, and we found reasons for the patient's symptoms and signs. We use a tool called the Gamma Document Browser, which is essentially a database program to store all of the records that we take. And as she showed, it's important that we take complete records. A seemingly perfect case from an orthodontic standpoint was imperfect. This patient had discs that were displaced. Now I want to take you back in time to the 1970s, where our dear Professor Slavicek came up with this fundamental principle called the nathologic triad. Even back then, he recognized a fundamental principle that function and dysfunction are multifactorial. They require a personalized approach, hence personalized dentistry. He looked at three main factors, one being the temporomandibular joint, two, the muscles of mastication, and three, harmonization of the occlusion. Interestingly, when we look at these three together, which he called the nathologic triad, we come up with a complete diagnostic picture. Now, no clinician, no researcher lives in a vacuum. Professor Slavicek in his early years was influenced heavily by Dr. Bob Ricketts, the American orthodontist. In later years, by Dr. Sadeo Sato, who has actually given much to all of us. We wrote a paper in the Anglo Orthodontist published in 2023. You can see the cast of characters that contributed to this paper, called Dentistry by the Rules of Nature. And if you want to learn more about the interaction between these three amazing professionals, you can read this paper. You're welcome to take a picture of this QR code. It actually has all of the VieSID research publications, and we like to make them open access so that you can get them readily. All of our students that enter our programs learn about the cybernetic system of the masticatory organ. Norbert Wiener, back in 1949 in Vienna, wrote a book called Cybernetics. Professor Slavicek applied this in a very, very profound way to the masticatory organ. He recognized that the environment heavily influences the organism. And of course, this is reciprocal with the organism affecting the environment. The masticatory organ is thereby influenced as part of the organism both ways. And he divided this into three main areas of focus. The first is the central nervous system, comprised of the soma, CNS, and the psyche. You'll hear a lot at VieSID about function. We need to believe that the mandible is continually moving, and those functions are absolutely affected by the occlusion, the joint, and the muscles. Mastication, speech, respiration, posture, appearance, and stress management are the main focuses that we use. The structures that we key on are the neuromuscular system, the muscles that drive the bones, the articulation, which is the occlusion, and the Kraniomandibulyar system, which I will define for you later. You can think of it at this point as the temporomandibular joint. Another thought experiment, and I want you to look at this inverted pyramid and try to decide where you are at in your education right now. I titled this The Hierarchy of Dental Therapies. And what you see is an inverted pyramid with 6 levels. As we rise up the levels, we increase the complexity of our dental therapies. Now at level 1, we know that we have to eliminate infection and pain. And at level 2, we do simple treatment with one-tooth dentistry. Now, every graduate as a dentist from dental school has to be able to accomplish these two levels. Otherwise, you wouldn't graduate. In North America, we have the term Walmart, which is a large chain, of course, that has very large number of products. But if you choose to practice dentistry like this, you don't set yourself apart. It's like shopping at any big box store. You can find the same things. And then we use that analogy. Our patients can't tell the difference between one dentist and another. But at level 3, when we start to get more education, we can tackle some moderate difficulty patients. Typically, we treat these in intercuspal position, or ICP, and we might do some dentistry in sextants or quadrants. At level 4, we add anesthetics, and we start to reconstruct people, again, entirely in intercuspal position. I want to focus your attention, though, on level 5 and 6. In level 5, we do complex interdisciplinary treatment of a functional system using a therapeutic position, THP. Now, I'm going to define that for you a little more clearly later. Many of us now, with Professor Slavicek's teaching, live at this level, level 6. We treat dysfunctional systems using a therapeutic approach with a therapeutic position. So how does this look like when we apply this to our patients? Here I show you 4 different cases from my practice. They're not atypical of patients all over the world that present to us. In the number 1, upper left corner, we see we have missing teeth. We see we have a curious cant of the maxilla. The incisal plane is very off. The upper left is higher. The upper right is lower. Clearly some problems. What about number 2 with the deep overbite and really, really profound aesthetic challenges? Number 3, this patient has absolutely worn down the dentition heavily. We have problems with altered active eruption, altered passive eruption. And number 4, really, truly, this is a combination of all of the above. We see wear, we see cants, we see missing teeth, etc. We need to have metrics and we need to have plans for each of these individual cases. Again, we need to be precise in our thinking. I want you to study this for a second. This is a truly complicated case. To give you some insight, this patient came to my practice with significant joint problems on her left side. She has so much going on: wear, old restorations, aesthetic challenges. How would you approach this? Where would you start? One of the main components of our treatment and therapeutic planning is a diagnostic wax-up, but this is not just aesthetic, it's actually functional. Now, this functional diagnostic wax-up was done by my colleague Stéphane Provencher in Quebec in Canada. You can see the beauty of this is hand-done, developing a technique where we can take this information, go forward with it, and create our treatment planning. And at the end, we can come up with a functional plan for a case that is still an open bite, but has perfect guidance, laterotrusively, mediotrusively, and protrusively. We've reduced and almost eliminated the joint symptoms. Everywhere I go, I get asked this question. So I've studied with Pankey or Spear or Dawson or Coyce or a variety of other educational institutions, and I get asked, so what's the difference between VieSID and all of these centers? Well, I can say that each of these institutions provides good educational experiences. Their planning, though, tends to be by box. So what do I mean by that? That means if you fit the box, you're going to get that treatment plan. There's a lack of information about treating and understanding the patient at the level of the temporomandibular joint. There are some guidelines for creating function, and there's some guidelines for treating dysfunction. But in most cases, how do you know how to do that? with these institutions. At VieSID, we treat using the precision dentistry principles. We understand the level of function and dysfunction at a core level. We always treat to improve the patient's function, no matter how they're functioning now. And we understand what's happening with the joints, the muscles, and at the level of the teeth, the nathologic triad. We try to create harmony. And we do that by taking a variety of metrics, a variety of diagnostic principles, just like little jigsaw puzzle pieces, and we put them together to create our diagnosis in an organized fashion. So with that preliminary talk, I want to now do an occlusion medicine primer for you. Again, my job and task today is to summarize what you've heard, step back, and try to give you some information that you can now use. The beautiful dissections that you saw from Westison and Erickson show a normal temporomandibular joint. Here again, we have two components, which is rotation and translation. Muscles drive the condyle forward, ligaments support the condyle, and we know that posterior to the condyle is the bilaminar zone, the retrodiscal tissues. The fibroarticular disc should be interposed between this condyle and the articular eminence in function. But when we look further at this concept, we see that Henry Gray, way back in 1897, was discussing these principles. He stated that temporomandibular articulation was really two distinct joints, one between the condyle and the disc, and the other between the disc, cartilage, and the glenoid fossa. Again, in 1897, he talked about the lower joint space having rotation and the upper joint space having translation. So as the mandible goes forward from a passive retral border, we see that against the articular eminence in the first diagram, in an excursive movement, it creates a positive pressure. Simply put, this squishes the synovial fluid out of the joint. But as the mandible comes back, as the condyle comes back, it creates a negative pressure, which forces synovial fluid into the joint. So in a normal, healthy synovial system, we are getting constant lubrication of this joint. This term you will hear constantly from all of us at VieSID, hinge axis of the mandible. I'm going to explain why, but by the definition, it's a line passing, usually, not always in cases of dysfunction, through the left and right condyles, which coincides with the center of rotation of the mandible. Usually, at the level of the incisors, this is about 19 to 20 millimeters of opening, or for most people, about 2 fingers of opening where there's pure rotation. Now, every joint in the body that rotates has a hinge axis. Of course, geometrically, the hinge axis must be part of the mandible. Because the mandible and hinge axis move together, they create one functional unit. Again, an older paper called by Bosman in 1974. And it was called Hinge Axis, the Effects on Occlusal Contact. And when we locate the hinge axis accurately, as Anastasia showed, we can truly accurately transfer the cast to the articulator because the maxillary cast position is identical to where the patient presents. This absolutely enhances our diagnostic precision, allowing us to make verticalization on our patients, for example, in wear cases, without geometric distortions. But what does that mean? Bosman did a great job, and I'm going to get you to refer to the diagram. If you look at the arrow pointing at the number 1, that is the true hinge axis located appropriately. Now, at the level of the teeth, we see where, for example, the molar and the incisor closes to. That's number 1. Now, if you were to mount your cast with an anatomic face bow, otherwise known as an ear bow face bow, you might pull it forward and it would be in position 2. But when you mount those casts, not on hinge axis, on your articulator, look at where number 2 goes to. It goes at the level of the molar, far more anteriorly, that's the red line, and at the level of the incisor, far more anteriorly also. What does that say? That says that the clinical situation does not actually match our instrumental situation. This is key. Now, this is a mandible moving in protrusion and retrusion. You see the green lines? What those green lines show is that protrusive pathway, but it's actually the movement of the hinge axis that is being depicted here. Now, the term right mediotrusion refers to the right condyle going medially, also called mediotrusion right. Now here we have 3 views. The big picture on the left is from the anterior, of course. Upper right is the sagittal picture, and lower right is from the superior view. If you look at the upper right picture from the sagittal, you see that beautiful anterior concave curve that's created by the movement of the hinge axis going in right mediotrusion as the mandible moves to the patient's left. In an open-close motion, it's a symmetrical movement where we have movement of the condyles forward, rotating, and translating. And again, we can study this, the green lines from the sagittal, from the side, as I said, and from the superior views, watching the hinge axis move. So let's review the terminology. As the mandible here moves to the patient's left, we call that a mediotrusion right or right mediotrusion motion. At the level of the teeth, in this case 237, that's said to be moving mediotrusively. The lateral intrusive condyle on the opposite side kind of rotates. And at the level of tooth 3-7, it's called lateral intrusive motion. We have mediotrusion right. At the level of the teeth, the 4-7, we have a mediotrusive movement. 3-7 goes lateral intrusively. And the opposite side condyle to the movement is called the lateral intrusive condyle. But there are synonyms to this. When we look at the synonyms, we see that the right mediotrusive condyle is called the working condyle. The 4-7 is now on the balancing side, mediotrusive side. The lateral intrusive condyle is the orbiting condyle. And at the level of the teeth, we see 2-3-7 is on the working side. Using hinge axis to study motion, though, we can study complicated movements such as mastication, which initially, as we open to take a bolus of food, is a symmetrical opening movement. The mandible then goes back on the working side to its most retral position, unstrained. At that point, the opposite side is only halfway back, then it goes fully, and then we close into ICP. Seen from the side, we watch the movement of the condyle. At the level of the hinge axis. We see that pattern of hinge axis like Anastasia showed, which is not symmetrically the same as you go excursively and incursively. Why might that be? Perhaps we have a disc displacement in this curve also. Here I'm going to show you what she showed you in electronic condylography. As the condyle moves, we're looking at various views, and we see that same curve if you look at the large picture in the middle left, which shows a changing characteristic and a changing curve. But what are we actually looking at when we're looking at condylography? I added some graphics so that you can properly see how this is working. What you're going to see here in the center pictures, the sagittal view of the hinge axis moving. If you look at the far left and the far right pictures, you're seeing the condyle move level of the hinge axis from the anterior. The last views are the top views, which show the right condyle from the top, left condyle from the top. Now, these views are turned, and the only reason they're turned is just so they fit on the screen. Again, the upper left grid tells us at every given point in hundredths of a millimeter how the mandible, the condyle is moving. We have timing, and we also have measurements. This is how we can study at a very accurate level movements within the temporomandibular joint. This gives us metrics beyond what an MRI would that we can use for our therapies. The red line depicts excursive movements or eccentric movements. The green line is an incentric movement. Now, the eccentric movements tend to be related to bruxism. That's going from in to out with a lot of friction. The incentric motions tend to be more functional, such as mastication. As you've already heard, we had used different planes to coordinate all of the instrumentation that we have with our patient. But just to define and review what those planes are, first we have the red line, which is the occlusal plane. We define this for our metrics as the tip of the lower incisor to the distal cusp of the lower 6-year molar. Now, we can have a different occlusal plane on the right side and the left side. And there are other occlusal planes that we might use in our diagnostics, but this is the key. The second line, which is the Frankfurt plane, is the blue line. That's from the infraorbital point, the top of the external auditory meatus. It's the plane that you get if you use an ear bow or an anatomic face bow. Lastly, we have the axis orbital plane, which by definition goes through, again, the infraorbital point, but also goes through the hinge axis. Therefore, we have to determine what that is in order to use this plane. The sagittal condylar inclination is measured by condylography, and it's related to the axis orbital plane, the green line here. Synonyms to sagittal condylar inclination is the horizontal condylar inclination. Different people present with different sagittal condylar inclinations. The transverse condylar inclination, or TCI, is measured using condylography, using a reference line. For example, the green line here is a perpendicular to the hinge axis. The red line is the movement inwards as the condyle moves to the opposite side. That's the transverse condylar inclination. It's incredibly important at VieSID that we measure cusp inclination because we can actually create our restorations to improve function. Cusp inclination is seen here on a sectioned molar, and it's measured relative to the occlusal plane. You've heard the term therapeutic position. Short form is THP. Now, this is a treatment position that does not correspond to the initial presenting position. Anastasia showed you a VTO, the visual treatment objective. When we're doing our therapies using our cephalometrics with our models, etc. at hand, as well as our condylographic tracings, we can predict where our treatment may go. This is hugely important before we actually begin to touch the patient. Again, we can overlay cephalometrics so we understand at a skeletal level what's going on with the face, the maxilla, the mandible, the cranial base. We can overlay our condylographic tracings using our X, Y, and Z coordinates. So let's look at some basic movements now at the level of the teeth. I want you to study this picture. What you see here are 4 lines, red, green, yellow, and blue. Each line depicts a movement of the upper cusp against this lower 6-year molar, tooth 4-6. As we draw back out, what we see is a blue line corresponding to the lateral intrusive movement. Yellow line is lateral end protrusion, green is protrusion, and the red line is medial intrusive movements. Let's focus on the left picture and focus only on tooth 4-6. What we see here is the blue line goes direct lingually. We see the red line goes distal buccally. So the blue line corresponds to a lateral intrusive movement. And that, of course, is the mandible moving to the patient's right. Easiest way to think of it is think of taking a pencil, putting it perpendicular to that tooth, just like the cusp. It stays static as the mandible moves, and try to predict where the pathway will go. But when you really carefully look at this tooth, you see breakdown on multiple levels as the patient has worn the tooth down. This is called a medial-intrusive interference. So that medial-intrusive pathway occurred because teeth have worn down, and now this tooth, which is tipped, is now in function. A true medial-intrusive pathway is one, or interference, is one where, as the mandible in this case goes to the patient's left, the only guidance is on these teeth, 1-7 and 4-7. So to reiterate that, a medial-intrusive interference is going to be as this patient moves their mandible to the left, where the only guiding surfaces are the 1-7 and 4-7. Now that's not a good thing. What are the consequences of that? You see here in the bottom picture, with the blue line, mandible moving to the left, we see these teeth are worn where the blue circle is. Now as these teeth wear down, the potential of getting a medial-intrusive interference on the opposite side, which of course is the upper picture where the red is, increases. The consequences of a medial-intrusive interference can be pain, both in the joint and the teeth. Well, the teeth can move because of the different forces on it. You can get fremitus. Fremitus, by definition, is vibration, and typically this would be of the upper tooth as the mandible moves to the patient's left. We can easily fracture the upper cusp or the lower cusp. We can load the periodontium, and further on we can get distraction of the condyle, as this movement, largely occurring during bruxing potentially, will pull the condyle down, stretching and tearing the ligaments, distracting the condyle. So I want to discuss the anterior teeth now. The anterior determinants of occlusion have been talked about for a century. So why does this type of thing occur? And how can we design our reconstructions with proper anterior function, minimizing risk to the teeth, minimizing friction? You'll recognize this as a typically restored lingual of the upper dentition in this patient. Now the backstory is that these crowns were placed 6 years prior to me seeing this patient. And I doubt the diastema was there. And what you see is a very rounded, thick lingual. Function was not considered. We all know that canine guidance, theoretically, is something that is desired. But where did that come from? Well, Harvey Stallard in the 1930s was working, of course, with dentures, as everyone was at the time. And in dentures, they were using bilateral balance occlusion to keep the dentures in place as the patient was functioning. The problem was when you went to the dentician, the natural dentician, to do crowns, etc., it was almost impossible to implement a bilateral balance. So he came up with the thought that if you create canine guidance, it'll drop the back teeth apart and all will be well. Dr. Bill McHorris in the United States, a fantastic paper from 1989 focused on anterior guidance and came up with 5 principles. Number 1, ideally the anteriors guard the posteriors when you're bruxing. This, of course, will reduce the effect of creating medial-intrusive interferences like I just showed you. This friction will produce wear on the anteriors, though, and he wanted us to understand how to minimize that friction. The studies showed that friction decreased with a cuspid disclusive angle equal to the condylar disclusive angle in a 1-to-1 ratio. Well, what does that mean? If I, using condylography, can establish that I have a 44-degree sagittal condylar inclination, for example, on my right condyle, I can set the lingual of my upper left cuspid at 44 degrees. Thus, as the condyle moves down the eminence, medial-intrusively from the right condyle, and the lower and upper left cuspids rub against each other, if those angles match, we greatly reduce the friction and thus the wear. We know that anterior disclusion significantly reduces the electrical activity of the masseters and pterygoids, largely from Eugene Williamson's work. And the anterior teeth disclusion produces a class 3 lever in function. So to summarize, we have metrics where we can measure the condylar inclination and set the teeth at good inclinations to get the ideal guidance. Looking at these pictures, it's curious that when we're born, we have no sagittal condylar inclination. Our mandible just moves forward and back, and that, of course, is to nurse to gain nutrition. But around the age of 6 to 7, we start to develop an eminence, and this would be as the teeth start to articulate, as the incisors come in. In a fully grown adult, we have a full sagittal condylar inclination. Now, this is how we develop. But the question is, now that we're looking at the incisors, is there a relationship between the anterior guidance and the condylar inclination? Well, the studies show that that difference is about 10 degrees. Again, it's 0 for the cuspids. So once again, in our example, if we have a sagittal condylar inclination of 44 degrees, and we set our incisors 10 degrees more than that, that creates the least amount of friction and the best function. Of course, you're asking, how do we measure the lingual of the incisor to get that value? I want you to look at the term F1 on this diagram and F2. If we take those 2 points and draw a line up to the axis orbital plane, we get an angle called the incisal guidance angle. Now, this is very different than what we do supplementarily when we trace the long axis of the teeth. That's not a functional surface. This is truly a functional surface. F1, or function point 1, is where the lower incisor hits the upper incisor in ICP, and function point 2 is the farthest protrusively the mandible moves. We can study this, and we do, as one of our tests, by making a putty index of the upper model mounted in axis orbital plane, and we can section it. Professor Slavicek did this on 1,200 consecutive patients at the University of Vienna. Again, you see here the axis orbital plane, the top of this SAM articulator. We see some putty, and we see a cross-section. And that cross-section is done perpendicular to the axis orbital plane. We can then measure F1 and F2, and here in this graph, we see a very high bell curve at 10 degrees. So again, the incisal guidance inclination, 10 degrees greater than the sagittal condylar inclination, was by research showing that the best inclination for an upper incisor is 10 degrees. I wanted to explain 2 further studies to you by my friend and colleague that I did my master's degree with, Dr. Ken Tamaki from Kanagawa University in Japan. These 2 studies, among others, are very, very critical to designing all of our teeth. I'm going to show you the first study, which is involving the teeth involved in lateral guidance and the muscle effort to make the mandible move sideways. And the second study is the steepness of the guidance all the teeth that are involved and their effect on muscles and the temporomandibular joint. Once you've seen these studies, you will approach your practice in a different way, and I will show you why. This first study involved taking patients and putting artificial gold overlays on teeth to become the lateral intrusive guidance. So here we see in the upper left gold overlays that are on the 3s, and those are the only teeth touching as the patient goes excursively. He then added the 3-4, then the 3-4-5, then guidance on the 3-4-5-6, and the 3-4-5-6-7. Now, Dr. Tamaki then did EMGs of these. And as he did, you can see in this bar graph that when only the cuspid in 4, and the cuspid 4 and 5 hit, the EMG activity is very low. But as soon as the 6s and the 7s hit in excursive movements, the bar graph jumps tremendously, showing much higher muscle activity. So what's the practical take-home of this? In all of our reconstructions, in all of our fillings, in all of our orthodontic treatments, we want to avoid contact on the molars as the patient goes laterally. The second study showed steepness of the guidance and the effect on the muscles and the joints. In this case, he took, again, overlays on the cuspids only. And what he did is he made those cuspid overlays at the SCI, or the HCI, the horizontal condylar inclination. Then he made them steeper at 5 degrees. Then he made them steeper at 10 degrees. And then finally, he made them steeper at 15 degrees. And using condylography and EMGs, he studied the effect. The results were fascinating. As you increase the steepness of the cuspid guidance, he showed that the hyperactivity in the masticatory muscles increased. He also showed that the steeper it got, the more weird lateral displacement of the mandible that happened. It actually induced temporomandibular joint dysfunction. And finally, and most importantly, it caused a backwards and upwards movement of the condyle on the side of the steep guidance with a lot of increased digastric muscle activity. So if we just try to make all of our cases designed by cuspid guidance, we have to know what that guidance is. And in many cases, we can't get it. For example, in a Class 2 Division 1 with an overjet. It's important that we have metrics that allow us to set our cuspid angle, our incisal guidance, at the correct inclinations. Otherwise, we can create pathology. One other really important fact is called the intercoronal opening angle. We see here that the steepness of the anteriors is dictating the opening angle. The key is this red triangle. The lower incisor is touching the upper incisor at the F1 point, but we need to have some freedom, that triangle, when we create our reconstructions. If we don't, we can definitely induce pathology. In this case, this is an excellent example of a case without any intercoronal opening angle. Our next term that we're going to look at is reference position. Now, we've all heard the term centric relation. Why do we need to know this? Well, we know that the teeth and the condyles are inherently connected. We have one mandible, two condyles, and the teeth. So whatever influences the teeth will affect the condyles and vice versa. This debate has raged my entire career. Having graduated in 1982 with centric relation, still a concept that was incredibly important. It raged throughout the 80s and the 90s. Professor Slavicek recognized this as a term that was tough to define and very hard for people to get a handle on. Before we go there, I'm going to define what I said before, the craniomandibular system. In the craniomandibular system, we have the basic osseous structures. which include the condylar process and the articular eminence. In addition, the temporomandibular joint region with the middle ear and the temporal bone. We have ligaments that suspend the mandible and the hyoid bone. Most importantly, the sphenomandibular, stylomandibular, and the stylohyoid ligament. Now we have the temporomandibular joint itself, which has the joint capsule, the capsular and temporomandibular ligament. We have, of course, the articular disc and the retrodiscal tissues. And I also want you to consider the craniomandibular system muscles. Now, these are specific muscles that are actively involved in movement of the condyle and the disc. That's the superior head of the lateral pterygoid, the deep head of the masseter, shown in green here, and the frontal head of the temporalis, which in 30% of the cases actually is active in pulling on the disc. So if any of these or all of these have some hyperactivity, you can understand that they're going to displace the disc. In a normal opening joint, we know there's rotation and translation, and the disc follows in a nice way, keeping the lubrication as I explained before. But what happens in a case where the mandible closes, we have an interference, and that interference drives the mandible to a position that is non-physiologic at the level of the joint, shown here by the green lines? That interference will definitely create a movement in the joint that we do not want. As I said, Professor Slavicek recognized the challenges with the term centric relation and the variety of different definitions. He tried to come up with a consensus as to why we need a joint position in the first place for our diagnosis, and what would be the most intelligent, simple way to achieve its finding. Now, he was a physician first and a dentist second. Back in the day in Vienna, dentistry was a specialty of medicine. He knew through his medical training about the neutral zero method. This was first illustrated by Caves and Roberts in 1936, and it recognized that all joints in the body have a range of motion, an area of hypermobility, shown here in purple, and what's called a neutral starting point, a neutral zero for function. Now this is an example with the elbow, but you can see the elbow flexed, you can see it stretched out, extended, and the area of hypermobility. Now the original diagrams showed all the joints in the body except one. This, of course, is the temporomandibular joint. Presumably, it was because Caves and Robert recognized that this is the most complex joint in the body, having rotation and translation. But Professor Slavicek thought maybe he could use the neutral zero method to define a repeatable starting position or neutral zero position for the craniomandibular system. So what is this position? Well, we know that in the temporomandibular joint, there's a ligament called the discocondylar ligament that in healthy joints resists unforced retral movement. We know that as the mandible goes in a passive way forward and back, it will be stopped by the discocondylar ligament with help from the bilaminar zone. We know that this is a reducible position, and Professor Slavicek believed that this could be used as a zero reference position for our diagnosis and treatment planning. So reference position, what we teach at VieSID, is the unstrained retral border position that is patient-derived. What does this mean? If the patient translates their mandible forward and goes back without us pushing or doing anything to increase pressure, that position is a reference position, and it is a repeatable position. So what's the difference between centric relation and reference position? Centric relation tends to be a point relationship of the lower jaw and the glenoid fossa. It's generally a manipulated position using a leaf gauge, for example, bimanual manipulation, and usually the therapeutic position is the same as the centric relation point. Reference position is a position of the mandible that's non-manipulated. We use something called chin point guidance, which is not pressure. It's just very light touching of the chin to make sure that the patient is in their most unstrained retroborder position. And we use it as a starting point to find a therapeutic position when necessary. It's a starting point for our treatment planning, but it's not always the place where we will restore the patient. We use all of our metrics, all of our tools to diagnose the patient, reference position being one of them. Two more terms for you. The first being a retral contact position, or RCP. RCP is the contact of a tooth or teeth along the retruded path of closure. Now, when that happens from that RP position, we're going to get at the first tooth to touch. It's the initial contact of a tooth or teeth during closure around the horizontal hinge axis. In this case, in RCP, we see this tooth contacting the 1-6 and the 4-6. Now, ICP is the complete intercuspation of the opposing teeth. It's the best fit of the teeth, regardless of the condylar position. The synonym for this is maximum intercuspation. So why is this important anyway? Well, we know that slides from RCP, the initial contact and reference position, to ICP have to be individually assessed for their effect on the joint. We look at this three-dimensionally, and we know that through research, Professor Slavicek's, that the RCP to ICP slides in most healthy joints are within 0.5 millimeters. Now that's measured at the level of the joint. But if they become bigger than 0.5 millimeters, we know that the level of the joint, they can create compression of the joint or distraction of the joint. In addition, at the level of the teeth, they can create increased muscular involvement as the patient tries to close to ICP. This is a hugely important slide, which when you're studying with VieSID, you will see repeatedly as we go. A quick background on this patient. This patient was a fully treated orthodontic patient. We see the ICP above, we see the RCP contact below. Her chief complaint when she came to my office was pain in 1-6 and 4-6, to cold particularly, and joint problems on her right side with clicking. She was finished orthodontically in the upper position, an ICP. However, if the orthodontist had taken the time, as Anastasia showed, to fully diagnose the case, it was not finished. Her RCP contact was only the distal buccal cusp of the 1-6 and the distal cusp of the 4-6. This created muscular involvement to close her to ICP and significant joint problems on the right side. The last topic I want to cover, sequential guidance. We've all heard the terms cuspid guidance schemes. We've heard group function schemes. Professor Slavicek stepped back and looked at an occlusal scheme that mimics nature, which he called sequential guidance. Remember that our goal is to create an environment where function is allowed to happen unimpeded by our dentistry. We don't want to create problems, we want to create function. Just like nature, the teeth sequentially disocclude with the absence of balancing interferences, no lateral intrusive interferences, and we can create this based on each patient's individual, unique situation. This is an example of the harmony and sequential guidance scheme for one patient. Here, using condylography, we can understand that our sagittal condylar inclination is 50 degrees. You already know from what I've told you that we want to keep our cuspids at about the opposite side, at about the same inclination. If you look below, we see the cuspids at 48 degrees. Now we actually have guidelines going anteriorly and posteriorly from the canine with the exact inclinations that will be ideal for function in a harmonious sequential way. Retrusive guidance is a concept that you've heard. Retrusive guidance is very critical when you are actually creating a therapeutic position. So if we don't accept the presenting condylar position and we actually create a new mandibular position forward of where we are, what can happen? Well, every protrusive position of the mandible can go back. It needs what's called a retrusive control. As I said, anything that goes forward can go back. Initially, as the teeth come in, nature uses the maxillary sixes with the transverse ridge for retrusive control. Think about a class 1 occlusion. In creating our reconstructions, we take advantage of the premolars. They do centric loading and transfer to the palatal vault through the palatal cusp, but we actually create guidance so that as the mandible closes into an anterior position, it is a trigger that stops the mandible from going retrusively. That holds the therapeutic position. We call the area that we work in the playground for functional geometry. I've given you a lot of definitions, but if we know the occlusal plane angle, also the arch width, the sagittal condylar inclination, the Bennett angle, the TCI, the intercondylar distance, the cusp inclination, and the lateral intrusive guidance, we can combine these in various combinations to eliminate or create interferences if we do it wrong. These factors are in turn influenced by skeletal type, skull type, mandibular type, the tooth morphology, and the CMS health. As Christian Slavicek, Joanna said, as well as others, VieSID is now digital, which opens up a whole new realm of possibilities for the future. Each of these digital technologies allows us to add to our ability to individualize our functional dentistry. The workflows that we have are indirect and direct. Indirect meaning taking analog impressions, using a very accurate lab scanner to create our digital casts, or a direct flow using intraoral scans. In the indirect digital workflow, we use analogs to produce physical models. We do always use hinge axis location, with the gold standard being a metal stylus perpendicular to the skull that we can visually watch rotating to find the hinge axis. We marry that to our electronic condylography, find our RP, our reference position, using different plastic or wax plates. We do a hinge axis facebow transfer, as I said, to create an accurate position of the maxilla to the condyles. Then we scan the models into the lab scanner and do virtual articulation. VieSID, we teach splints. This is called phase 1 therapy, and really they fall into 3 categories. The myopathic splint, usually just for muscle pain. And generally we use these for 4 to 6 weeks. Verticalization splints, when a patient is severely overclosed, often we'll use cephs to determine an ideal vertical. And we commonly use this prior to new dentures when the old dentures are severely overclosed. Finally, the CMR appliance or stabilizer, which we've all made reference to. This is our go-to for arthrotic joints, degenerative joint disease, disc derangements, and when we're trying to create a more favorable therapeutic position. For stabilizers, we have to be very careful. We must use condylography, and we recognize that they're non-reversible treatments. Our RP will change when we do this. We have to understand that sometimes repositioning the mandible can create more complex dentistry. We may need orthodontics or prosthodontics, and we need excellent pre-treatment planning. But the results are overwhelmingly favorable, and our patients will attest to that. Again, we use condylography, as Anastasia showed, to pick a therapeutic position. We create test bites using usually Futard D, which we can go to the mouth and test using muscle palpation before we create our stabilizing splint. Our playground of instrumentation is fantastic. I'm old enough to have used various systems in my career, and I have to say nothing compares. The beautiful sequential incisal table for waxing, which you see here, allows us to build our cases with proper guidance. And the various instrumentation that you've seen allows us to control our treatments from diagnosis through therapy and beyond. To summarize the VieSID concept, we're all about ensuring excellence in our patient care. And again, that goes back to being precise. We use organized systems and workflows that we define. The key concepts which I reviewed today are hinge axis, sequential guidance, reference position, therapeutic position, and the playground that we call functional geometry to create the proper tooth form. We individualize our cases based on function, and we build stuff to last. We plan properly, and our main goal is to avoid iatrogenic consequences. From my own experience, I can absolutely attest that this creates satisfied patients, a happy, motivated staff, and it gives you in your career a fulfilling vocation. Myself and my teachers have been blessed to have learned from many. None more important than our mentor, Dr. Slavicek. And I thank him. And I thank you. It's been an absolute pleasure to share this information with you. I look forward to meeting you.
Robaczku! Jeszcze chwilę.
And thank you very much for listening to me as the last speaker.
Testerian, thank you for interesting presentation. Sertifikatı təqdim etmək üçün Azərbaycan Tibb Universitetinin Ortopedik Stomatologiya Kafedrasının dosenti Asif Əxməmmədovu dəvət edirik. Təxminə xanım. Təxminə xanım. Bir neçə dəqiqədən sonra VYANA İNTERDİSİPLİNAR Stomatologiya məktəbi ilə F arasında müqavilə imzalanacaq. Hər kəsi bu mərasimdə iştirak etməyə dəvət edirik.
Okay, so we are coming to the end of our meeting, and it is for me a great pleasure and honor to work with such great people like you and the whole IFO study group. And I would like to congratulate you for this wonderful event. I know what's behind and what work it is. So thank you so much. And now I think we get something official to sign, and I'm looking forward. Now it's you.
Hamınıza EFO adından, VieSID adından, sonradan işini davam etdirəcək, proyektləri çox böyük olan VieSID Azərbaycan adından təşəkkürümü bildirirəm. İnanın ki, zalı belə dolu görüb qürurlanıram. Amma bayaq Güney xanıma balaca bir məsələni demək istəyirdim. Səhnəyə çağırdılar. Həmin məsələni Güney xanım sizə ünvanlayıram, amma hamınızı ünvanlayıram. Səhiyyənin başqa ixtisaslarından, mütəxəssislərindən fərqli olaraq bizim nəzəri biliklərimiz icebergin görünən hissəsidir. Amma bizim işimizin keyfiyyətli olması üçün həm nəzəri biliklərimiz həm dərin, həm keyfiyyətli, həm kalitəli olmalıdır. Həm də işin nəticəsinin yüksək səviyyədə olması üçün pasientlərimizin doğrudan da mükəmməl müalicə, diaqnostik planlara nail olması üçün bunların nəzəri hissəsinin praktiki chairside, yəni kürsünün kənarında xəstələrə lazım olan səviyyədə, yüksək səviyyədə həyata keçirməsindən çox vacibdir. Ölçülərin düzgün götürülməsinə, modellərin düzgün tökülməsinə, reference pozisiyasının düzgün götürülməsinə, kandilografiyanın düzgün həyata keçirilməsinə, hinge axis'in düzgün tapılmasına, yəni hər etapda mükəmməllik tələb edən bir proyektin, bir yolun başlanğıcıdayıq. Hamınızı təbrik edirəm, hamınıza minnətlərim.
Just some more small comments from my side. I would like to say a big thank you to all our team, to all our teachers, which gave their knowledge and spent their time to come to Azerbaijan or lecture by video conference. You did a really great job, and I think you deserve another big applause, please, for the teachers. And last but not least, my congratulations to all of you who took the chance to meet us here in this wonderful location. It is exceptional to see so many interested dentists and dental professionals in function and occlusion. So thank you from my side again, and now we are probably ready to firm the cooperation.
Nasıl?
Vətənimizə, millətimizə xeyirli olsun inşallah.
Konfransın elmi hissəsi başa çatdı. İndi isə musiqili hissəsi başlayır. Çıxış edəcək Azərbaycan Respublikasının əməkdar artisti İlham Nəzərov.
Lord. Sogno all'orizzonte mancano le parole. Sì, lo so che non c'è luce in una stanza quando manca il sole. Se non ci sei tu con me, sole le finestre, mostra il tutto il mio cuore che hai acceso. Chiudi dentro me la luce che hai incontrato per strada. Time to say goodbye. Quasi che mamma adesso si vivrò con te, partirò. Sonai per mani che io lo so, ma non esistono più. It's time to say goodbye. Quando sei lontana sogno all'orizzonte mancano le parole. E io sì lo so che sei con me. Mia luna tu sei qui con me. Mio sole tu sei qui con me. Time to say goodbye. Paesi che non ho mai veduto lì sotto con te. Adesso si vivrà con te. Partirò. Per mari che io lo so, non esistono più. Con te io li vivrò, con te partirò. Su navi per mari che io lo so. Dünyası sen, anamın anasısan Azerbaycan. Ты меня зовешь, Азербайджан. Ты во мне поешь, Азербайджан. Как огни твои светлы, как слова твои теплы, ты звезда моей судьбы, Азербайджан. Как огни твои светлы, как слова твои теплы, ты звезда моей судьбы, Азербайджан. Ey eski sanam Azerbaycan, sene bağlıyam Azerbaycan. Ömrümün mənasısan, kardeşlik dünyasısan, anamın anasısan Azerbaycan. Anamın anasısan Azerbaycan. Ey eski anam